Good afternoon, everybody, and welcome to the third Retina Australia webinar for 2021. Clinical genetic services helping with genetic information, counselling and access to clinical therapy, trials and research into the IRDs. My name is Sally Turnbull and I'm the Administrative Officer for Retina Australia, and I will be the facilitator of this webinar today. As a participant, your camera and microphone will be switched off throughout. There will be an opportunity for you to ask questions once all our speakers have finished their presentations. If you have any queries during the proceedings, you can type a question to me in the Q&A section. Now I would like to introduce our speakers today. We're delighted to welcome Professor Robyn Jamieson, Dr. Alan Maher and Ms. Laura Wedd from the Department of Clinical Genetics, Western Sydney Genetics Program, Sydney Children's Hospitals Network and Westmead Hospital. Professor Robyn Jamieson is Professor of Genomic Medicine, University of Sydney. She leads the Epigenetics Research Unit at Children's Medical Research Institute, Sydney Children's Hospitals Network and Save Sight Institute. She heads the Epigenetics Clinic, Sydney Children's Hospitals Network. Her work demonstrates novel inherited retinal dystrophy gene and variant identifications with translation to clinical testing. Professor Jamieson's laboratory is investigating patient-derived retinal organoids using gene editing and replacement strategies to test new genetic therapies in the IRDs. Professor Jamieson's work contributed to the first ocular gene therapy approval for clinical use in Australia, a breakthrough for previously untreatable retinal diseases. Dr. Alan Maher is a clinical geneticist at the Children's Hospital Westmead. He has a special research interest in genetic eye conditions and has just completed his PhD with the Epigenetics Research Unit at the Children's Medical Research Institute. Laura Wedd is Sydney Children's Hospital Network Coordinator for the Ocular Gene and Cell Therapies Australia program. She is also the Genomic Eye Coordinator within the Epigenetics Research Unit at the Children's Medical Research Institute. She has a background as a genetic counsellor and genomic scientist. So our first speaker today will be Dr. Alan Maher, and I'd like to introduce him now. Thanks so much, Alan.
Thank you so much for letting us come and speak, and I'd like to thank Retina Australia for giving us this opportunity. We're going to be talking about clinical genetic services and how we can help with genetic information, counselling and access to clinical therapy and trials and research in the inherited retinal dystrophies. And as the first part of this talk, I'm going to talk about a bit of an introduction to inherited retinal disorders, as well as referral pathways in ophthalmology and genetics and genetic testing approaches that we take. So I probably don't need to tell this audience about what genetic retinal dystrophies are, but just a brief overview, they are fairly common. They affect about 1 in 1,000 individuals. And the main kind of subgroupings of these tend to be conditions that affect the rods in the back of the eye more than the cones, like retinitis pigmentosa, where there can be loss of peripheral and night vision first, or cone rod dystrophies that affect the cones more than the rods, and the central vision tends to be affected first, as well as color. And over time, these can lead, you can get rod and cone degeneration, which can lead to complete vision loss. When we think about the genetics of these disorders, that it is actually quite complex because of the optic pathways and the way that light is converted into a nerve signal for our brains to interpret. That pathway is extremely complex, and so there are hundreds and hundreds of genes involved in this pathway. And at the moment, we think there are more than 200 retinal disorder genes, and they have something called high heterogeneity, which this kind of Venn diagram helps to explain. While we have all these individual clinical diagnoses like Stargardt's or cone rod dystrophy or retinitis pigmentosa, the actual individual genes that can cause these, you can see here, there's a lot of overlap between the different clinical conditions. Some genes can cause multiple things, while some are unique only for particular clinical subgroups. And so when we think about the genes and genetic testing for this, it can get quite complicated because these genes, some of them kind of moonlight and do several things. The other thing to take note is that there are some syndromal links. And in genetics, when we talk about syndromes, we usually think about things that affect the vision, but more than that. So they can affect other organs in the body, or sometimes even the way that the brain develops and intellectual development as well. And so why is a genetic diagnosis increasingly important? We're seeing a lot more demand for genetics in retinal disorders. And really, one of the main reasons is it provides a bit more clarity in terms of the actual diagnosis, and sometimes for the prognosis of the condition as well, so how it might progress. Like I mentioned previously, some of these genes have syndromal associations, and it's sometimes useful to know about these, especially in children, because these can have additional health implications that need to be monitored and managed. One of the main reasons that we do genetic testing is really to think about family planning and recurrence risk counselling. Many of these disorders are inherited in different patterns, and you'll hear about this later from Laura's talk, such as recessive and dominant inheritance, and these have really important reproductive implications for the next generation. And so when couples are planning a baby, they may want to know what the genetic diagnosis is to help to clarify what the chance is of passing this on. Increasingly, a genetic diagnosis is useful to help guide treatment decisions, especially in this era where gene therapies are now available. And so you probably saw on, I think it was Thursday on the ABC, the announcement of Luxturna, which is the first TGA approved gene therapy in Australia, which is now available. And there are multiple trials for additional genes, and you'll hear a bit about this from Robyn's talk later about other genes that there might be trials for, and increasingly these therapies are going to be available. At the moment, for our patients, we have a number of recommendations in terms of the pathway for them to receive an ophthalmic and a genetic diagnosis. Firstly, to see their GP if there are concerns about their vision, but especially if there's any concern about a family history of a retinal dystrophy, because many of these do run in families. The GP can do an initial assessment and then refer that patient to an ophthalmologist for a more detailed assessment. And most ophthalmologists will examine the back of the eye, but also perform some additional testing, such as electrophysiology, to really map out what's happening, especially to the rod and cone cells in the back of the eye. What the ophthalmologist can also do is provide ongoing follow-up and management, and also, if they are suspicious of a genetic form of retinal dystrophy, refer on to genetics. And the role of genetics is really to help to provide some genetic counselling about the inheritance of the condition, but also to help arrange testing to really pinpoint which gene is involved in that retinal dystrophy. And so in terms of what we do in genetics, we help families to understand how genetic conditions are inherited, but also we talk through in quite a lot of detail about the actual genetics of these conditions. And the main reason for doing that is to help families understand genetics so they can consent to testing. And when we do the genetic testing, we actually do this on DNA. So I've got a picture here of a person, and what we do is everyone's made up of trillions and trillions of cells. All of these cells each contain a complete copy of the DNA code that's kind of like the blueprint for life. And inside that DNA code here, you can kind of see it's tiny, and when it's unwound, you have all these individual letters that spell out genes, and the genes are the recipes that make things, and they can make things like our hair color, our eye color, how tall we are, all the little intricate things of our bodies. And we think about 200 or so of those genes make recipes that are important in how your retina functions. And so we try and focus on those retinal genes when we do retinal gene testing. Now, when we test about 200 genes, it's actually quite tricky, and you can get quite a number of outcomes. And it's really important that we have really, really good clinical information. So what the ophthalmologist thinks is going on in the eyes of an individual to help to guide that gene testing, because there's basically 4 outcomes when we do any genetic test. One is we might find a genetic cause. So we might find a gene, a change or a spelling mistake or an error in that gene that can cause, for example, retinitis pigmentosa. And if that matches up with what the ophthalmologist thinks is going on, then that's great. That's the answer. We sometimes find this thing called a variant of uncertain significance, and that can happen up to about 15% of the time. And this can cause a lot of anxiety because it's a change in a gene that we just can't interpret whether it is the answer or whether it's not the answer. And so that might need some additional studies in that individual or in their family or even in a research lab to really try and work out what it means. Very occasionally, we find something called an incidental finding, which is a change in a gene totally unrelated to the retinal dystrophy that we're looking at. For example, a cancer gene or something else. That's very rare that we find that, but we always warn families about this. And we also sometimes get a negative result. And a negative result doesn't mean that it's not genetic. It just means that we haven't been able to find the specific answer for a family in the genes we've tested for. And there are still probably hundreds of retinal genes out there that haven't been discovered yet. And so if you have a change in one of those genes, you may end up with a negative result until research catches up and is able to find that gene. And so, like I said before, with over 250 genes testing, it really helps to have a really clear idea, especially from the ophthalmology, about what area of genes that we want to test. And this is a very detailed table, but it just gives you an idea when we see patients with retinitis pigmentosa, we think about these key genes, and it helps to tailor the testing to an individual. Whereas in cone dystrophies, we think about these genes, and in Leber congenital amaurosis, we think about a totally different subset of genes. And you can see here, when we try and pinpoint the genetic testing with what the clinician thinks is going on, the yield of testing is actually fairly high. So in retinitis pigmentosa, it can be as high as 65%, 60% in cone and cone rod dystrophies, and even up to 80% in Leber congenital amaurosis. And so what do we mean when we say, we're going to do a genetic test? There's several approaches, and actually, I think in terms of this audience, if you're from all over Australia, it kind of depends on what state you're in and what your local clinicians do. But essentially, there's several different ways that we can test these genes. The commonest way is to do something called a gene panel, where we basically test the 200 genes or 100 genes or 50 genes associated with a particular condition of interest in an individual. But increasingly, because genetic testing is getting cheaper and more accessible, we may test an entire genome of a patient. And that means all 20,000 genes. So we all have 20,000 genes. But we usually only analyze the subset of genes that we're interested in, like those 200 retinal genes. Sometimes an individual can just be tested alone. And sometimes we might even test an individual with both their parents. And one of the reasons for this is that when we do this type of genetic testing, you can get a lot of these variants of uncertain significance. And so having your parents' DNA there can help with the process of interpreting your genomic data to try and filter out some of the noise that might be there that you've inherited from your parents. Now, each state has their own kind of different approach to this, but most states will have a standard referral lab with some expertise, especially in retinal dystrophies, that will perform this type of expert testing. And increasingly, there's overseas labs that are available. So there are overseas commercial labs that are very good in places like Finland and the United States. Interestingly, recently, some of them have been offering some free testing. And we think there's a few caveats to this, because depending on which state you are, have some free testing through your local genetic service. And sometimes that free testing doesn't come with all the counselling and the additional services that you would get from your local service. Well, I think that's the end of my section, and hopefully this will transition smoothly to Laura's talk.
Thanks, Alan. So I'll just pull up my slides for my presentation, so just bear with me while I do that. So today what I'll be taking you through are some of the genetic counselling aspects. So if we meet a person in the clinic, what we might run through with a person in the clinic with some example cases. and also touch a little bit on genetic testing consent and results, as Alan has taken you through. So in terms of being referred to a genetic service, if a person's referred to a genetic service, they'll typically be seen by a geneticist or a genetic counsellor, or sometimes both. A geneticist is a medically trained doctor with special training in genetics, whereas a genetic counsellor is an allied health professional, also with special training in genetics. And as Alan has touched on, genes are messages that instruct the cells of our body to work. And we know that there are many genes, over 200 genes, that are really critical for the way the cells of the eye work. And a genetic condition essentially happens when one of these genes isn't working properly in the body. Our genes come in pairs, so we get 2 copies of every gene, and this is because we get 1 copy of every gene from our mum in the egg cell that makes us, and 1 copy of every gene from our dad in the sperm cell that makes us. And if we say take a blood sample from a person and take out the genetic information from their cell and look at it down the microscope in the laboratory, what we usually see is something that looks a little bit like this. So these long structures here are actually called chromosomes, and our genes are scattered all along the chromosomes. We get 2 copies of every chromosome because one's come from mum, one's come from dad, and they're numbered chromosome 1, 2, 3, all the way down to 22. This last pair here are the sex chromosomes. So they're different between males and females. Males typically have 1 long X chromosome and a shorter Y chromosome, whereas women typically have 2 X chromosomes and no Y chromosome. When we think about retinal dystrophies, we know that they're inherited in a number of different ways, and it does depend on what particular gene is affected. It could be that there are no copies of a particular gene working properly in the cells of the eye, what we would refer to as autosomal recessive. It could be that only 1 copy of a gene is working, but the other copy does not work, and this is enough to cause the condition. This is what we refer to as autosomal dominant. And it could be that a gene on the X chromosome isn't working properly, what we call X-linked. And I'll take you through these 3 most common scenarios in a moment. The genetics team will assess a person's own history and their family history to think about whether there's likely to be a genetic basis to their condition. And if the geneticist does think that there's a genetic basis to their condition, they can consider whether genetic testing would be indicated. At a genetics appointment, the genetics team will typically take the family history and draw out what we call a pedigree. So if you're not familiar with pedigrees, they're a way of drawing out the family history. In these diagrams, males are indicated as a square and females are indicated as a circle. A person who does not have a condition is not coloured in, but when we meet a person who has a condition, we tend to indicate this by shading it in black. In this particular case, as an example, this man, he has retinitis pigmentosa. He has a sister and parents, and none of them have retinitis pigmentosa, and no one else in the extended family has RP. So in this particular case, we meet him in the clinic and talk to him about the option of genetic testing. He decides that he's okay with going ahead of having a genetic test, and so we organise that for him. In this particular case, genetic testing identifies that neither copy of a particular gene called RPE65 is working properly. And RPE65 is a gene that sits on chromosome number 1. So remembering that he got 1 copy of the RPE65 gene from his mum and 1 copy of this gene from his dad, and neither of these gene copies is working, which is why he's developed RP. When we go and do further testing in his parents, what we find is they are what we call healthy carriers. So they have both his mum and dad have 1 completely working copy of the RPE65 gene and 1 non-working copy of this gene, which for them in the cells of their eye, the working copy is enough to function. And this is why they do not have RP and will never develop RP. But what it meant for them when they had their children was that there was a chance, a 1 in 4 or 25% chance, that every child they have could be affected. And this would happen if the sperm cell containing the non-working gene copy comes together with the egg cell not containing the non-working gene copy. And this is typical of autosomal recessive conditions. In his particular case, he wanted to know what his chance would be of having an affected child also, and it would only be if his partner was also a carrier of a gene change in RPE65 that would stop it from working. In many instances, it might be that his partner is not a carrier, in which case there would be an overall low risk of them having a child who could develop RP like he has. In another example, we meet another person. This particular man, he also has RP, and when we take his family history, we find that his dad also has it and his grandmother. And in these particular cases, when we see multiple generations affected, this is typical of autosomal dominant conditions. When we do genetic testing in him, it identifies that one copy of a particular gene, and this gene is called the RHO gene, is not working. This gene sits on chromosome number 3. So he has one completely working copy of this gene, but one copy that does not work. And for this particular gene, that's enough to cause RP to develop. When we do further testing in the family, we confirm that both his dad and his grandmother have the same change, and that's why they also have RP. And so in the case of autosomal dominant conditions, for any generation, there's a 50-50 chance that they might pass on the non-working copy that can cause RP. For couples who are considering planning a family, where there's a higher chance of having a child born with a genetic condition, some couples might consider reproductive options. So these are options where testing can be performed on embryos, where couples go through a cycle of IVF and they do special genetic testing on the embryo before putting it back into the womb to ensure that only the gene copy that works is passed on. In another scenario, couples might think about testing a pregnancy in the early stages. And if the results from this testing show that the non-working copy has been passed on, the couple have the option to stop the pregnancy. Not all couples would choose these options, but they are available. In another example, we meet this person in the clinic. He also has RP. And when we do genetic testing in him, we find that he also has a change in the same gene, the RHO gene, causing the dominant RP. So he has one working copy and one non-working copy. But when we took his family history, neither his parents or no one else in the family was affected. And when we did additional testing in his parents, we found that they did not have the same change that he had. And that's because for a small portion of people, sometimes that change is a new change that happens in the sperm or egg cell that makes them for the first time. So it's occurred for the first time in him. And that's why there's no family history. But it does still mean that for him, there's a 50-50 chance of passing that on if he decides to have children. In this final example, it's again a very similar family history. We have a man who has RP, and when we do genetic testing in him, it identifies one copy of the RPGR gene is not working. And this gene copy actually sits on the X chromosome. Remembering that men have one X chromosome and a Y chromosome, where women have 2 X chromosomes and no Y chromosome. So for him, the RPGR gene copy on his X chromosome is not working, and he doesn't have that particular gene on his Y chromosome. So he has no backup, and that's why it has caused RP in him. When we do further testing in his mum, we find that she carries this same change, but as women have 2 copies of the X chromosome, she still has a working copy of that gene. And so she doesn't have retinitis pigmentosa and is what we call a healthy carrier. For X-linked conditions, there are different implications for men and women. And so in the genetics clinic, they will talk about this with individual families as it applies to them. But for this particular person, if we think about his chance of having a child born with a similar condition to him, we know that his daughters will be carriers like his mother, so he'll pass on the X chromosome, but they'll have their backup chromosome, X chromosome that they've inherited from their dad, so won't be likely to develop the condition. And his sons will inherit his Y chromosome. If we think about arranging a genetics test is usually a blood test. And before having a genetics test, it's important that the doctor arranging the test or the genetic counsellor takes a person through an appropriate consent process. And this is because it's quite important to think about a number of things before having a genetic test. It's important to think about the benefits and limitations of testing and what it means for a specific individual. So a genetics doctor will talk to a person about this and what it means for them in more detail in an appointment. They'll also talk about the different result outcomes that Alan's touched on and different implications for that particular person and their family depending on what the result is. So there are sometimes implications like implications for life insurance and, as Alan mentioned, incidental findings. So finding somewhat unexpected things, and also that sometimes in genetics testing is indicated in other family members. For each person considering a genetic test, it's important that they consider how they might adapt to new results and implications of testing before having that test. In terms of receiving genetic results, we know that a clear cause might be found from genetic testing. This is sometimes called a pathogenic or likely pathogenic genomic variant. So pathogenic just essentially means disease causing. This can help an individual understand their chance for having a child with the condition, as in the examples that I've shown. In terms of family planning as well, it can help inform family planning where potentially partners can have genetic screening to understand a couple's risk altogether, or a couple might choose reproductive options such as IVF with prenatal genetic diagnosis. So that's the testing of embryos, or prenatal testing. Additionally, a genetic test result might change a patient's management or medical treatment. So your geneticist or ophthalmologist might suggest changing medication, for example, from the result. And other family members may have testing even if unaffected, what's called predictive testing. As Alan mentioned, no genetic cause may be found, and this doesn't mean there isn't a genetic cause, it just means that we haven't found that at a particular time point. And sometimes when we do a genetic test, an unclear or uncertain result can be found, what's referred to as a variant of uncertain significance. And in this case, further testing may be required to understand whether it's causing the condition or not. Of course, every family is different. And so sometimes different family members will have the same genetic change, but have no signs at all, or they may have very mild symptoms when another family member is more severely affected. And of course, different family members and different people will react differently to results and make different choices about whether they would like to have a genetic test or not, or whether they would like to use reproductive options or not. And so the genetics team is there to support a person through the process of having a genetic test and help them make the decisions that are right for them. And that's the end of my particular presentation. So I'll stop sharing and then hand over to Robyn. Good, thanks.
Hi, everyone. So I'm talking on part 3 of our trilogy of talks here. And also thank you to Leighton and the Retina Australia team as well for this invitation to talk, to try and give you some more information about the genetic side of the ocular genomics pipeline that we're interested in. And so what I'm going to be talking about is the ocular genomics multidisciplinary team and how we find that really helpful in working through some of the genetic side of things, and some of the research that's important in terms of interpreting some of the genetic variants. You've heard about variants of uncertain significance, and then some of the novel therapy work that we're doing, and then the clinical trials and clinical therapy side of things. So this is an overview of where we really want to be with patients and families with inherited retinal dystrophies. And this is our ocular gene and cell therapies pipeline. So we have people with vision impairment. So it's very important that we have diagnosis and staging of their condition from the ophthalmic point of view and also the genetics point of view, as we've talked about. So the multidisciplinary team is very important in this, with a really good working relationship between ophthalmology, clinical genetics and laboratory genomics. We need to think about things like therapy suitability. We need to think about what's called functional genomics, which is a way of working on this variant classification issue that we can sometimes have when variants of uncertain significance are found. We need biomarkers to assess new therapies, and we need this very detailed research work as well for novel mechanisms and to develop new therapies. And then if at all possible, we want to be able to take people on a pathway to either an internationally approved gene therapy, for instance, the RPE65 gene therapy, voretigene neparvovec, or Luxturna is the trade name, if that's the suitable therapy for that particular person, in that they have the RPE65 gene changes and the other relevant features. Or we want to be able to offer people clinical trials, if at all possible, and I've mentioned some of those there. And then we also want to venture into the brave new world of investigator-led clinical trials and novel genetic therapies for these conditions, so that we may be able to provide options for patients in terms of either a clinical therapy or a clinical trial approach. And so in terms of requirements for genetic therapies, it's absolutely critical to have a genetic diagnosis, because this the therapy frequently relies on a particular genetic diagnosis. And one also has to have a clear-cut clinical diagnosis in terms of the retinal dystrophy. And then you also need to have the appropriate disease staging, an appropriate number of viable retinal cells to give the actual therapy into. And so that's why the multidisciplinary team is really critical to get all those aspects working together. So just to give you an example in terms of the criteria for suitability for therapy for RPE65 related retinal dystrophy. So this is the one that is actually clinically available in Australia now. A person has to have a clear-cut clinical diagnosis of an early onset retinal dystrophy or Leber congenital amaurosis. They have to have a genetic diagnosis of pathological biallelic RPE65 mutations. And so what that means is that you have to have those pathological variants in RPE65, and it has to be shown that one of them came from your mom and one of them came from your dad, which is indicating that it's biallelic, that they're not both variants on one chromosome, they're present on both the chromosomes, which is indicating that it's a clear-cut explanation for the disease. You have to have sufficient viable retinal cells, and this is a clinical assessment that's made on the basis of the constellation of ophthalmic features, for instance, the visual acuity, the visual fields, various other indicators that are looked on from the ophthalmology perspective. And these are criteria that have been delineated for us by the TGA, the Therapeutics Goods Administration in Australia, as being requirements for RPE65 gene therapy. It is interesting to note there is no specified age requirement. So this is something that is very much a clinical assessment and isn't a specified age requirement, although someone in the very first year of life that might be a particular issue, but certainly beyond that, it is available for people further on in life as well. And so in terms of the RPE65 gene therapy, as I mentioned, this is a clinical treatment, clinically available in Australia now, and successfully delivered in Australia to 4 patients so far who are doing very well. And as Leighton or Sally mentioned, or Lowen, not sure, mentioned, there was a program related to that on the ABC News, a section about the first 2 patients treated in Australia with that therapy. So as I mentioned, the reason that we think the multidisciplinary team is so very important is that we need to put it together. As Alan and Laura have both mentioned, we need to put it together that the clinical diagnosis of what the ophthalmology team is finding needs to fit together with what the laboratory genetic findings are. And then it needs to make sense in terms of how the pedigree is looking and the available information in the literature about the particular the condition and the particular types of variants or genes that are associated with that, because it is a complex puzzle sometimes. And so it really often does take that team approach to be sure that we have the right genetic answer for a particular patient and family. And these are just examples of the various ophthalmic features and conditions and the various testing that needs to happen to be sure about that. And the RANSCO guidelines were made available last year, and these are helpful in terms of being sure of the right answers from this perspective. And then these variants of uncertain significance are raising their ugly head in this field. So as Laura mentioned, often we get a clear-cut genetic answer, but sometimes we do get, probably in about 10%, 15% of cases, we get something called a variant of uncertain significance, which is really, really annoying for everybody. This is one family, this is an exemplar case that we have worked on, where this is a particular RPE65 situation, and one of the variants was a clear-cut pathogenic variant, but the other one is a variant of uncertain significance. So one of the problems with the RPE65 gene is that it's only expressed in the RPE, which is the retinal pigment epithelium at the back of the eye, and we're not able to biopsy any of that tissue to look in more detail at expression of that gene. And so one of the things that we do in the research lab is use stem cells for disease modeling. So this is to help us be able to find those answers for those variants of uncertain significance. So in this process, what we do is we take a sample from a patient, from their blood or their skin, and de-differentiate those cells into what's called induced pluripotent stem cells. And then they form this kind of patch of undifferentiated cells, as you can see here. But then we're able to re-differentiate them to make them turn into either retinal pigment epithelial cells, developing here, or into what's called retinal organoids, which have the layers of the retina in the dish. And then we use these cells to model the particular variant to try and understand if we can change it from being a variant of uncertain significance to a likely pathogenic or pathogenic variant, which we can then use for interpretation for the family and then potentially eligibility for therapy. So in this particular example, we found that variant of uncertain significance, it looked to us like it might be causing what's called a splicing problem, which means in the gene, it's not working altogether to make that gene properly. And we were able to confirm that by looking at these RPE cells that we'd differentiated from the IPS cells from a patient in that family, and show that was not a variant of uncertain significance. It was actually a premature stop codon, indicating that was a likely pathogenic variant. And so those patients could then become eligible for therapy. And this is an emerging issue, of course, when there is eligibility for therapy hanging on this sort of work. And we've now actually got 2 more referrals related to this sort of issue. So this is something that's going to become increasingly important. And so we've also got strategies for developing the retinal organoids. So because some of the genes are not expressed so much in the retinal pigment epithelium, they're particularly expressed in the retina itself. And of course, again, we can't take a biopsy of the retina to do these very detailed studies in these genes that are only expressed in the retina. So we have to make the IPS cells and differentiate them into the retinal organoids. And you can see that you can get there's quite nice photoreceptor layers in these organoids. And we're also doing other studies on other variants of uncertain significance to determine if they are actually disease causing in the same way that I just described for that RPE65 variant. So these are all of the approaches that we're taking, and we're also using the retinal organoids to develop new therapies because sometimes you need to do a replacement therapy or you need to do a gene editing therapy. You've probably heard about CRISPR-based technology and so on to develop these novel therapies so that we can provide therapeutic answers for an increasing number of patients. and then also work on more of the clinical trial aspects. This is obviously all important for improved situations for families. So I want to thank all of the people involved in this work. And as this was particularly a session about understanding the genetics and the genetic information side of things, I'll put that, that web address there, which I'm sure Sally and Leighton would be happy to share, which is a way that you can find out in your particular area, no matter where in Australia that you live, where your nearest genetic service is, that you could ask your GP to refer you to if you would like, to. And I've also put the web address there of our lab in case you're interested in some of the work that we're doing. And I want to thank very much all of the people in my team who've contributed to the research work, and of course also all of the ophthalmologists and the laboratory teams that we work with to make this improve the situation as far as we can for patients and families. So thanks very much, and I'm sure we'd be happy to take questions.
Thank you all very much. That's fantastic to hear about what the work that's going on. So we do have time for questions now, and we've already had a couple, but I just reiterate, if you want to ask a question, you can type it into the Q&A section, or you can use the raise hand option at the bottom of your screen, and we'll respond to those as well. And we'll be able to get you to turn your microphone on and you can actually ask it yourself. If you are unable to see the Q&A thing at the bottom, or if you're unable to press the raise hand thing, you can also use Alt-Y to raise your hand. And if you're on the phone, you can use *9 to raise your hand. And to unmute your microphone, you can select the unmute button on your screen, or just press the space bar. And if you've joined on your phone, to unmute, you need to press *6. So let's get started. And there's a couple of questions here. Here's somebody, Esther has asked, has said, I have RP with 5 to 10% vision left. Female, 42 years old, non-Australian. Genetic testing is not available in my country or region. Would I be able to do genetic testing in Australia? If yes, which state or facility has this available for non-Australians? And is there any organisation I can get in touch with for this?
Yeah, I guess there's a few individual particulars in there that probably we could deal with offline, might be more easy to do. But certainly there are labs in Australia that will accept referrals from international labs to do the testing. So there's definitely ways that could be worked out. And I mean, it becomes an issue of cost and potentially, depending who will be able to pay and that sort of thing. But often these things can be worked through. And as Alan mentioned in his talk, most states in Australia, for Australian patients, there is a cost-free option that can be taken. But it does take working through a little bit of the time. But we'd be happy to work with that person to try and figure out what the best way would be forward for them.
Great, thank you so much. Here's somebody else asking, is genetic testing covered by Medicare?
So it's not actually covered by Medicare at the moment, but it's covered by the state departments, generally speaking. So each state has its own particular arrangements, and usually that's covered by the state health service.
Okay, thank you. Alison has said, I have 2 sons with Xlinked RP and was of the belief that they would not be able to pass the condition on.
So yeah, so they can't pass it on to their sons. That's correct, because boys have an X and a Y chromosome. So if they've got Xlinked RP, then it's on their X. And so if they have a boy, they had to get their Y, so it doesn't have the gene on it. So that's correct. But the girls will be carriers. So because the girls will get that X chromosome with the change. So the girls will be carriers. Usually they wouldn't be affected because, as Laura mentioned about, they've got a backup copy. Sometimes they can be affected to varying extents. So yeah, that would be the situation. So that person, I mean, if they wanted to, they could seek some further genetic advice about that. Sometimes, you know, things can get confused, and you know, there's different knowledge at different time points about various things. So it's always good if, you know, people have queries that they can see their GP and get a referral to the genetic service again to clarify things, because there's been lots of changes in genetics and understanding of genetics over the years. So I think anyone's advised, if they're, you know, confused about anything, to see their GP and get a referral and to the genetic service and try and sort that through.
Great. We've had a couple of questions about Luxturna. One part is Luxturna treatment covered by Medicare? And secondly, how are the patients who are being treated with Luxturna reacting to the treatment, and how promising are the results?
Sorry, I might have answered that. Sorry. So there's negotiations going on at the moment. Luxturna therapy is currently free to, you know, the affected people. I mean, it has to be, you have to have the RPE65 gene and all of those requirements. But really a lot of the work that we have all done in the ophthalmic and genetics community is to make sure that that therapy would be not of a cost to a particular patient. And that has been achieved. There's further work happening, but that's the story. So what's the second question? Sorry.
How are people reacting?
Oh, yes. Yeah. So if you watch the ABC program, the first two patients are talking about their experience there. They've found it very beneficial. So I guess the first thing that you're trying to do with the Luxturna therapy is really prevent it getting worse. I mean, I guess that was the main kind of initial aim, to prevent things deteriorating further. But the people who've had the therapy are finding that they can see stars in the sky, which they couldn't previously see, and they can see things up close, like print even on occasions. I don't think that their vision, anyone would say that it was back to normal, but they're certainly seeing improvements, which is very exciting.
Fantastic.
Can I just say one thing, Sally?
Yeah.
The link to Leighton Boyd, for those who don't recognise my voice, the link to what Robyn's presentation about the ABC is actually, if people have got Facebook, they can look at Retina Australia's Facebook. It's there. You can listen to the presentation or read the presentation. It's described there. So I welcome anyone that didn't see that presentation to go there. Or we can make it available. Sally would be able to make that available through our office. So that's just a good. And Retina Australia and Retina International are working very diligently and hard, because I think one of the priorities of both organisations are to try and get free genetic testing. It's one of the most commonly asked questions of certainly me and our representatives over the years, about people wanting to find out, what do I have and how do I get it? So I think it's important to know, and I just encourage people to keep in touch with us, look at our resources, and keep in touch with. We're working very closely with Robyn and her team, and also people in the other states as well. And so I just encourage people to do that. Thank you, Sally.
Are there any free genetic testing options in Brisbane? We may have spoken about that already.
You know, I guess we don't know necessarily the particular situation in each state, but we do know that if you go to the clinical genetics service and talk to them about it, then you know, they are in a position to be able to offer you free genetic testing, depending on the, you know, the situation, basically.
And the Queensland Genetics Service should be available. Like the details will be on that Centre for Genetics Education website link. That's got a link to all the services in Australia who can see you locally.
Okay. Here's a question from Lauren saying, is there any clinical trial happening for Stargardts at the moment?
Yeah, so there's the Stargardt clinical trial is related to a particular oral therapy, and that's happening in certain centres across Australia. So it's happening in Sydney, pretty sure it's happening in Melbourne, and also WA, Western Australia. Yeah, it's a matter of being in touch with the ophthalmic teams and so on there, and the genetics teams, and working out what's available from that perspective.
Thank you. And here's somebody else asking, obviously there is a lot of scientific studies, journal articles and so on about family history aspect of retinal syndromes. Are you aware of any studies that are academic but non-scientific, suitable for the interested layperson? I guess, is there anything that's been written that you know about that might be easy to understand about all of the different work?
So Alan, you might want to mention about your book chapter, in fact. I don't know.
Yeah, we're writing a book chapter for physicians about inherited eye disorders. So that's going to be for non-genetics doctors who might want to read and learn about this. I don't know if the questioner is a medical person or a lay person. That I was just looking at the Retina Australia website. It's actually got really good information there that's really easy to read and understand, and I think it just goes into just the right level of detail for, so like there's over 12 conditions talked about there and genetics. So I think places like Retina Australia and other kind of patient support groups have a really key role in putting out excellent information. Some of the stuff in the older literature might be a bit out of date. So that's why websites and groups like this are really, really good for more recent updated material.
That's great. Thanks for the plug too, Alan. That's great. Here's a question from another person saying, are genetic testing results kept confidential?
Absolutely. That's part of the consent process. We usually tell a patient that it's their information and it's their private information. Obviously, the tricky thing about genetics is that once we find something in an individual, that may have implications for other family members, because we get all our genetics from our parents, and our siblings share our DNA, and our children as well. So usually through that consent process, there will be a discussion about who can you tell or not tell about this information, and you have a choice in that. But it's also important to think carefully about that, because if you don't want that information shared with other people, it might have important implications for them. That doesn't happen as much in retinal conditions, but might happen in things, really important things like cancer. If you have a cancer genetic thing that you don't want other people to know about, that could be really, really important information for them. So while it is confidential and you should only have access to it, there's usually a clause to allow other family members to access your genetic information to help them with their family planning or their management as well.
Debbie wants to know whether early treatments for RP limit options for other treatments as the knowledge advances.
That's always difficult to know. So, because sometimes clinical trials can say, people can't be having concurrent therapy, or a previous therapy might be making them not suitable, and so on. I guess all one can do is evaluate the information at the time. And just assess if a person was going to be offered some sort of therapy. That would be very much part of the assessment. What is the landscape at the moment? And this is why it's very important to have you know, the ophthalmologist, the genetics team, the laboratory team all talking together. What is the landscape at the moment for you know, particular therapies or particular therapy options for that particular condition? How much is that person's retinal condition deteriorating? How fast is that happening? What's the cost? What's the cost benefit ratio in a kind of a way to kind of give it a go with this clinical trial, say, rather than waiting for another clinical trial, and that clinical trial might be at an unknown point in the future. So sometimes, you know, a clinical decision has to be made about that, or you know, obviously in discussion with the person and thinking about, you know, where they want to be. So all of those things are really quite complex and difficult to give a blanket answer to.
Rod wants to know whether you have a view on the field of epigenetics, and in particular the work of cell biologist Bruce Lipton and neuroscientist Joe Dispenza.
I must apologise. I'm not particularly up with the particular literature. I'm not sure if Alan's had a chance to Google that, but so I guess epigenetics is a very interesting field. I guess at the moment we're getting a lot of answers out of straight genetic diagnostics without needing to consider epigenetics at the moment. I think that's probably going to be related to some of the more tricky things that we can't work out. I mean, as we've mentioned to you already, you know, we're getting genetic diagnoses in about 60% or so of people, and then we've got these variants of uncertain significance and so on. So obviously there's some people where we're not getting answers. You know, it's possible that epigenetics and so on might play a role there. At the moment, I'd have to say that we're focused on, you know, doing what we can for people and the best we can. And unfortunately, genetics is not an outrageously well-funded specialty in Australia. And so often the genetics clinics do unfortunately have queues for their genetics appointments. And we're trying to sort through those and work through those as best we can. And dealing with the known and what we can work out from that. I think these other areas, you know, they're always great in terms of research and so on and so forth. So it's likely there's going to be lots of things that come out of that in the future.
Esther has asked again a bit more about testing, and she's wanting to know what samples do you take for genetic testing, and if you're, you know, is there an issue with sending them? Do they get degraded? How easy is it to ship things around? If you are,
I was just looking at that question from Esther. It looks like she's from Malaysia. Maybe we can pass on an email address, because I think we do have some links to genetics people in Malaysia.
Fantastic.
That might be able to help you locally. I think the tricky thing about all this testing is just one part of that process, and having a good counsellor and a geneticist and an ophthalmologist locally who can talk you through those results is just as important as getting the actual test. But if maybe we can pass on our emails to you, Esther, and we can get back to you about that, because I think there are some geneticists in Malaysia that might be able to help.
Yeah, there will be. And I mean, but the DNA doesn't usually degrade, or the sample doesn't degrade necessarily. Depends locally. You might be able to have the blood sample extracted to make the DNA, and then that's really a very stable way to send the sample. But even a blood sample can be sent, and it can be in the post for some time, 7 days or something like that, and it still can have the DNA extracted. So that's not usually a barrier, but as Alan mentions, you know, getting the right genetic information and having someone help with interpretation of the testing is probably really the most critical thing there.
Great. And someone's asking, have there been any studies on the rate of degeneration of, I'm assuming, people's eyes in these different conditions? Yeah,
so there's a lot of studies nationally, internationally on that, and of course it depends on each person and their particular gene that's affected. So they're not all the same. All of these retinal dystrophies, as we've said, there's over 200 different disease genes, and so each of those have their own course and their own information, and even sometimes a particular type of genetic variant can make a difference in terms of how a condition progresses. So when you get down to it and thinking about particular therapies and so on, all of that needs to be taken into account.
And Rob Craft has asked, do you have sufficient people, numbers of people who are affected to be part of clinical trials, or are you always looking for more people?
Well, you know, always more people is great. There's really, because there has been genetic testing going on for quite a while now. There's often we often do have quite a number of patients available and interested in clinical trials, and then, you know, of course, across Australia in the various centres, we work together as well to work on those aspects. So that's usually not a problem, but certainly, you know, if people are interested, they can always be in touch. That's fine.
And one final question: what percentage of people who have genetic testing don't get a definitive answer?
Do you want to go?
Yeah, I think from that very busy table I had before, it kind of depends a bit on the reason for the testing. If for some different retinal conditions, the pickup rate for the testing is much higher, like the Leber congenital amaurosis was up to 80%, so 20% won't get a definitive answer. Whereas for other ones, like the cone dystrophies especially, maybe up to 40 or 50% won't get a definitive answer on testing. We do say that that doesn't mean you don't have a genetic condition. It just means we haven't found it yet. And so we think that re-looking at your genetic data every 2 years or so probably has a 10% increase in picking up answers, because new genes are being discovered and new methods of testing. So it's, I guess it's still unfinished business as part of genetics, and we would keep seeing and keep trying. And there might be a role for research as well for some families who don't have answers, to try and find those hard to find answers.
Great. Well, thank you so much to our speakers. And thank you for all the great questions from our participants.
I did see Sally, sorry, I did see a question there from Leighton. Can you get this treatment in RP65 if you do not live in New South Wales? And certainly, yeah. So I think that's an important question. So yes, it's certainly available to all Australians. And at the moment, there is one centre in Australia that's doing that particular therapy. That's in Sydney, New South Wales, with the intention that anyone in Australia can be able to access that. That would have to be there'd have to be work done to work on that. There are other centres in Australia who would like to be able to offer this testing, and that's a matter of testing therapy. That's a matter of working through with the particular government services and so on. I think one of the issues is that RPE65 is mutations are not outrageously common. So this is one of the struggles that happens with retinal dystrophies. There's so many genes, and there's small numbers of people potentially affected with each particular gene. And so I suppose, governments hesitate to set up very specialised centres for delivery of a gene therapy. I mean, it is a very specialised therapy. It requires a lot of management in terms of the particular medication, because it is the AAV that needs special handling and so on. So there's a lot of regulatory elements and so on. And so at the moment, Sydney is the centre in Australia, but any patient should be able to access that therapy. And I'm sure that as time goes by, other centres will open up as well.
Great. Right. Well, thank you very much. And I'd just like now to introduce Peter Mars, who's a board member of Retina Australia, to say a few words of thanks to our speakers. Thanks, Peter.
Thanks, Sally. Can you hear me okay?
Yes, we can.
Okay, good. I'm having some technological issues here, which I think are mainly called Peter Mars. But anyway, I'd like to thank Alan, Laura and Robyn for giving up their time today. It is a Saturday afternoon after all, and I would lay a bet that they've got other things that they would prefer to be doing, and it's so great that you can give us a few minutes of your time today. The presentations I found extremely interesting. And I think, given by the number of questions that came up, a lot of other people found them extremely interesting also. I'm impressed that they were presented very clearly in terms of clear explanation. Sometimes you watch a scientific presentation and there's all sorts of mumbo jumbo there that leaves us a bit cold, but congratulations to the three of you today for giving us such a clear explanation. And that was started off by Alan, and which grabbed my attention straight away and we got going. Laura, love the presentation with the genetic lines. I am unfortunately the unlucky 1 in 4 with no sign, no black dots above me and around me. So it was good to see that and get some explanation for that. And Robyn, thank you. For the first time, I've heard the word splice explained to me. So that was good as far as the chromosome is concerned. Thanks again for your time on behalf of all of us here at Retina Australia and the people who have joined this webcast. Really appreciate your time and thank you for coming.
Thanks, Peter. So that's the end of the webinar for today, and I want to thank everybody for coming and enjoy the rest of your weekend. Thank you.